privilege and honor to welcome all online participants of dental fraternity from all over the India and globe. A famous quote from our ex-president Kalam sir says, "All birds find shelter during a rain, but eagle avoids rain by flying above the clouds." Dental Council of India, under the able and dynamic visionary and progressive stewardship of the President Dr. Devendra Mazumdar, Secretary S. Saha, demonstrated the eagle-like qualities during pandemic COVID-19 by conceiving and implementing continued dental education platform in form of dental webinars. Today, we are in the 11th series of webinar, that is management of traumatic injuries to young permanent teeth. These webinars have proved boon for dental fraternity all over the globe, and particularly in India. I congratulate President DCI, Dr. Devendra Mazumdar, Sir, Secretary Dr. S. Saha, all the EC members and Dental Council of India members, and all the technical supporting staff in lighting the lamp for the dental fraternity. And this will brighten the path of the dental profession. Instructions to the participants. DCI webinars are free of cost to all the attendees. The attendees will have to register for each webinar separately. At the time of registration, complete and proper details must be furnished, since the same will be captured for generating the e-certificate CD points. Therefore, no request for any modification in the details shall be considered. An e-certificate of attendee will be considered to conferred to all attendees, including the undergraduate students, international attendees, and non-dentists on their registered mail. CD prints will be awarded only to a dentist registered with State Dental Council, and the tribunal's e-certificate will be sent to the attendee who will attend the entire session of the webinar uninterrupted, and may also be downloaded from the DCI website. In case of any query or issue, please drop email at webinardci@gmail.com. Last, highest attendee and the top 5 colleges in the country, it's my immense pleasure to announce their names, who have participated in DCI webinar on 6th September 2020. They are Saraswati Dental College, Lucknow; St. Joseph Dental College, Andhra Pradesh; JKK Nataraja Dental College and Hospital, Tamil Nadu; Cyber Institute of Dental Sciences, Andhra Pradesh; Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow. Heartiest congratulations to all these 5 dental colleges for showing their top presence for attending this webinar. Introduction to the speaker itself. There's a very famous quote from Swami Vivekananda. He says, "We are what we think. All that we are arises with our thoughts. We make the world." And this is true to Dr. Goyal sir, Virinder Goyal sir. He is having the voluminous CV. It will take considerable time for his introduction. Dr. Virinder Goyal sir is MDS, MFDS, RCPS. He is a member, Education Committee International Association of Pediatric Dentistry and Association of Asia. He is the president of South Asian Association of Pediatric Dentistry. He is a past president and general secretary of Indian Society of Pediatric Dentistry. He is an adjunct faculty, DY Patil College, Pune. And presently, he is a professor and heading the Department of Pediatric Dentistry in Guru Nanak Dev Dental College and Research Institute, Sunam, Punjab. As he proceeds with the presentation, just one point I say, today's presentation is the first in the series of pediatric and preventive dentistry. In the pandemic COVID era, all of us are very eagerly looking for the vaccine to arrive. But here we have one vaccine for the adult dentistry, and that vaccine is the pediatric dentistry. And if this pediatric dentistry is holistically used and applied, we can make the entire adult society free of all dental problems. You must be aware, from conception of child to maintenance of arch, integrity, and maintenance of the tooth structure, to the functional correction of soft tissue malocclusion. If all the preventive and interceptive protocols are applied, almost all the dental problems will cease to exist. And it is only the pediatric dentist who influences the future attitude of the adult toward the dentistry. Sir, Dr. Virinder Goyal, sir, presentation is like a small torch in the dark forest. He will not show everything once, but will throw enough light on the topic to the young permanent injuries to the young permanent teeth and how to handle this type of injuries in COVID-19. I hand over the space to the honorable speaker, sir. Well, sir.
Very good evening. Thank you so much, Dr. Rakesh Gupta, sir, for this wonderful introduction. It's an honor to share a dais with you, Dr. Rakesh Krishna Gupta. Dr. Rakesh, sir, is principal of Indira Gandhi Government Dental College and Hospital, Jammu. And he is a very, very honorable member of Dental Council of India. I am so honored to have you with me, sir, on this august platform. At the outset, I would like to convey my heartiest thanks to head of our dental fraternity and dental family, our Dada, Dr. Dibyendu Majumdar, our President of Dental Council of India, our very own Secretary of Dental Council of India, Dr. Sabyasachi Saha, sir, all executive members, chairman and member of subcommittee for the webinar, all DCI members for the opportunity given to me to serve in this capacity. It's really a wonderful and very, very valuable experience for me personally as well as professionally. I'm feeling very humbled, very honored and very special that you have given me this chance. DCI itself is a well respected and high regarded body, and it's really an honor for me to be part of the team which continues to strive to be on the cutting edge of this profession in the most modern way, like we are conducting webinars since few months. President sir and Secretary sir, on behalf of all dental professionals, please accept my massive thank you and appreciation for the excellent and enormous step of educating all of us during this COVID pandemic. Thank you once again, sir. So today I'm going to talk about management of traumatic injuries to the young permanent teeth. Although it is a huge topic, it's a big topic, but I'll try to confine it in 45 to 50 minutes. And I will be giving many good articles to read, because since many of the UGs, undergraduates and postgraduates and dental practitioners must be attending the lecture today. So it's my humble request that you can go through all these articles which I will be mentioning here. It will be really of great use for all of us in management of dental trauma. So as we all know, this is a beautiful article. This is the latest article on to the prevalence and incidence of dental traumatic injuries. It's a global meta-analysis. According to this, we have roughly 1 billion people in the world today who have dental traumatic injuries. Although it is not documented as far as the WHO is concerned, but traumatic injuries, according to this meta-analysis, could be the 5th most prevalent diseases or injuries, and first also being the dental caries. That's also one of the dental disease. The first could be dental caries, but 5th is traumatic dental injuries. That much amount of prevalence and incidence of these dental caries, this dental trauma is. So prevalence is roughly from 7.4 to 58%, and according to the literature, most of the injuries occur at home, not in the school, not in the playground, because in the school and playground the students are more disciplined, but since at home they are free to play on their will, so this trauma can happen at home. So now especially we will be talking about the young permanent teeth today. For undergraduates, let me make them little clear about young permanent teeth. The tooth which is recently erupted into the oral cavity, because of wide apex, it has excellent vascularity. It has excellent reparative power because a lot of vascularity is there. So it has reparative power. It can repair well. It can tolerate bit of trauma. But unfortunately, because it has recently erupted, the root length is yet to be complete. So a young tooth has incomplete root length. And there is minimal hard tissue support because secondary dentin, tertiary dentin is yet to be formed. So the roots are very thin and it has a weak wall. So now whenever the trauma happens, what are the goals of treatment? The goal of treatment should always be try to preserve vitality of the pulp. That is more important, rather the most important. And we should promote normal apical completion, and that is only possible if you preserve the pulp vitality. And if in few of the conditions you are not able to promote normal apical closure, at least try to do atypical apical closure. And if you are able to preserve pulp vitality, if you allow the tooth to grow, if you allow the root to grow, you can establish adequate amount of crown root ratio. That should be your goal of treatment. Now, whenever a trauma happens, whenever a child patient comes, there are few things we need to keep in mind. These are the points: medical history, neurological assessment, trauma incident, what happened, pain, bleeding, mobility. But four things are important for all of us to know is, first is neurological assessment, then when this trauma happened, where this trauma happened, and how this trauma happened. Because if you know the condition of traumatic injury, where this trauma has happened, you can plan your antibiotic as well as tetanus prophylaxis. Either it has to be a ready-made tetanus or it has to be a tetanus prophylaxis, therapeutic or prophylactic, that you can plan. And what kind of antibiotics are needed, that also you can plan. And so many other things you can come to know if you know when it happened, where it happened, how it happened. We will discuss all these factors in our coming slides. For all of you, this one article you must read. This is a very, very important article, very good article. All students, you can also take a screenshot of this so that you can download it later. And even you can watch these webinars, as Dr. Rakesh sir has already mentioned. that we have our website, Dental Council website. All these lectures will be there. Even at that time also you can take the screenshots. But this article you must download and you can know about management of trauma, and especially the diagnosis part, which is very, very important. And this is in general trauma sheet, which all we need to fill up whenever you get a patient of trauma. I'm not going to go into detail of that, but this sheet is already given in the article which I have already discussed before. So for the traumatic patient, whenever a trauma patient comes to you, a thorough medical history is important apart from dental history, and pain history of the pain is important. Now let's see one by one how we go ahead. This is the first step. So whenever a trauma patient comes to you, you just need to know about any other serious injury other than dental, because sometimes patient may have head injury, and in those patients dental injury is not that important at that particular time. So you need to take a history of the patient about loss of consciousness at the time of traumatic episode or little later. Any history of headache, any history of amnesia, any these kind of history, any history of vomiting, nausea, that is very, very important to know. This is the Glasgow Coma Scale. This is the one rapid way of assessing patients for any type of severe brain injuries. There are three main components of this. One is opening of the eyes, one is the verbal, second is the verbal response, and the third is the motor response. So this is the detail of what? In opening of eyes, there are 4 grades. In a best verbal response, there are 5 grades. And in a motor response, there are 6 grades. So these grades you must know. And in a Glasgow Coma Scale, you must see what is the cumulative score of these. Because if patient is opening the eyes spontaneously with your command, and patient is well oriented and patient obeys your command, that means that patient has a maximum score, and that means there may not be any head injury. So you can go ahead with the treatment. So Glasgow Coma Scale is very, very important for all of us. And after that, any jaw fracture. From a tooth injury, jaw fracture treatment is more important. So you must assess any potential jaw fracture. You must look out for any malocclusion, and for that panoramic X-ray or a CBCT, because most of our dental colleges have CBCT now. So we need to go ahead with the CBCT. And whenever there is a malocclusion, there could be 2 basic reasons for the malocclusion. One could be the bone fracture. Second could be the displacement of the tooth from its original position. So after you have looked about the head injury, after you have looked about the jaw fractures, malocclusion, now you need to look at the soft tissues. Any facial or the lip contusion, lip laceration, any gingival tear, because most of the patients will be bleeding. So you need to clear the bleeding first. You need to debride the wounds first. And if there is a lot of bleeding, you need to do the sutures. And then once the site becomes clear, it will give you a better ability to examine the teeth and record further dental injuries. So this is a trauma classification, one of the classification. It's nothing new. You all know about this classification. So one by one, we are going to take up the treatment of all these classes. So now I'll come down to the tooth particularly. After you have seen all those things, we will come down to the examination of the tooth particularly. Look for the fracture of the crown. Look for the amount of pulp exposure. Look for the change in color of the crown, any displacement, any mobility, any tenderness. So presence of discoloration might indicate pulp necrosis, but not always, because any recent trauma of a young permanent tooth, even if there is a pink discoloration, as we have already discussed, that the young teeth have lot of reparative capacity. So even minor pink discoloration will be fine. It will be resolved back, whatever the hematoma is there, into the crown, that is reabsorbed by the system, and the tooth remains vital. So whenever a mild discoloration is there, especially the pink discoloration is there, that does not indicate that the tooth will be non-vital in future, right? But the color changes of the crown could be because of three basic reasons. One is necrosis, second is calcific metamorphosis, that is continued calcification. But if there is a continued calcification, the color of the crown will be little yellow, and there will be a history of trauma in the past, because it takes many years for the calcification to occur. And there could be a pink discoloration or a pink spot because of internal or external resorptive process. So these could be the conditions as far as the color is concerned. And another thing is the pain. History of pain is very, very important if we want to check the pulpal status. And in case there is a provoked pain because of some stimulus, that means the pulp is reversibly inflamed, so it does not need removal. But if there is a spontaneous pain, the pain without even any aggravating factor, that means there is a widespread, extensive or degenerative or irreversible pulpal inflammation, or it could be even necrosis of the pulp. But the pulp response in a recently traumatized tooth should not be the primary finding, because whenever you do the pulp testing by using some cold or a heated gutta percha or electrical pulp test, whenever you do, and if you do not get a positive response, that patient doesn't feel when you apply these stimulus, that doesn't mean that should indicate for root canal treatment. So pulp response in a traumatized tooth, especially in a young permanent tooth, does not indicate that you should go ahead with the root canal treatment. If we look at the literature, in 1973, imagine so many years back, at that time Bhaskar reported that the pulp in a traumatized tooth can be in shock. So if a recent trauma is there, even if you don't get a response on applying any stimulus, that doesn't mean the pulp is non-vital. Because what we check by applying all these things is the nervous system. We do not check for the vascularity. The nervous system could be in shock, but still the vascular system will be maintained. So always wait till the time you do not get exact signs of necrosis of the pulp or pulpal involvement. Like in another article in 1996, Faglin also reported that the pulpal status in a traumatized tooth should be monitored for up to 5 years, and treatment should only be initiated when there is a clinical sign or radiographic change of development of apical pathosis, not only on the basis of negative pulp vitality tests. And another important thing here is, so whenever a patient of trauma comes to you and during a follow-up, if you take IUPAs during the follow-up, say after 3 months, after 6 months, after a year, and if you see a continued root maturation, right, or calcific changes, that means the pulp is vital. It may not respond to your vitality test, it may, but if these findings are there, a calcific changes into the pulp space on a follow-up X-rays, evidence of continued root maturation or closure of the apex, that means pulp is vital. You do not need to go with invasive root canal treatment. For any trauma patient, radiographic examination and photographic documentation is very, very important. Always take X-rays with your film holders so that you can have standardized X-rays and reproducible X-rays. And photographs for follow-up and for initial documentation are very, very important. because for medical legal purpose also photographs and x-rays are important. And from the x-ray also, from the photographs also, you can check for any change in tooth discoloration, any re-eruption of an intruded tooth, or any development of infra-positioning of an ankylosed tooth. All these things you can check when you take follow-up photographs, but that is only possible if you have taken the previous photographs, the initial photographs. Then we have these pulp vitality tests. I'm not going to go into detail of each pulp vitality test, but for us what important is that all the tests, most of the tests which are practically possible into your clinical setup, they check pulp sensibility, that is the neural response, but they do not check the intact vascular system. But true pulp vitality is the intact vascular system. So for that only two tests are available which are not practically possible yet possible. One is pulse oximetry, that is we check the oxygen capacity of the blood into the pulp, and second is ultrasonic or laser Doppler flowmetry, in which you actually check the flow of the blood. But these two tests are not practically possible, so we rely upon the test which check the pulp sensibility, that we check the pulp nervous system, not the vascular system. And especially in case of kids, because young permanent teeth will be in the kids only, in the children only, because these tests are unreliable, because you don't get reliable responses from children, because they are because they get fear. Management communication is a problem. They don't understand what you expect from them. So these tests are often reliable. So pulp vitality tests in young permanent teeth have very limited value, because these have inconsistent responses. So please be cautious when you do these tests, and do not initiate your root canal treatment only on the basis of these tests. Start the treatment on the basis of signs and symptoms of the patient, as well as on the basis of radiographic finding. So radiographic as well as symptomatic assessment should be your principal diagnostic criteria for starting any endodontic treatment. So we need to have accurate, organized and concise record keeping in case of traumatized dentition, as well as for the trauma of the surrounding structures. The documentation should be legible. The X-ray which you take should be of diagnostic quality, should be reproducible, and the photograph which you take should strengthen your documentation record. That is important. So record keeping is very important in the form of your history, as well as your radiographs and your clinical photographs. That's important. Now these are the few clinical treatment part. Like for enamel fracture, we do composite as well as the enameloplasty. For enamel and dentin, we do composite with or without calcium. And for the fracture with pulp exposure, we talk about direct pulp capping, pulpotomy and partial pulpectomy. Here we do not talk about complete pulpectomy, because our goal is to preserve as much as pulp we can. And for avulsion, reimplantation and supplanting. For concussion and subluxation, we give occlusal relief and we do the supplanting. For root fracture, we do reduction and we do supplanting. For extrusion or a lateral extrusion, we reposition the tooth back into the socket and do supplanting. For intrusion, we have orthodontic repositioning and supplanting. One by one, we are going to talk about all these treatment principles. So maintenance of vitality is very important in a young permanent tooth, so that we can complete the root formation. Because if you help the tooth in completion of the root, you will be strengthening the root walls. If the root walls are strengthened, the longevity of the tooth is more, so that the future root fractures can be avoided whenever a subsequent trauma occurs, or whenever the patient bites hard. If the root walls are not strengthened, there could be a root fracture, and then your tooth will need extraction. You cannot do anything more for that patient. Now, why this vital pulp endodontics is important, and what are the bases, what are the rationale of vital pulp endodontics is, in case of young teeth, in case of young patients, the pulp is more cellular. It is not more fibrous. So when more cells are there, it has ability to recover from any type of injuries. And secondly, if you try to do root canal treatment of a young tooth with a wide apex, with a thin wall, it becomes difficult to adequately clean the root canal space, as well as it's not possible to obtain a apical seal. So it's always better to preserve pulp vitality. And this is a beautiful article. According to this evidence, the teeth, even with complex crown fracture, even the pulp, if it is exposed, the pulp remains vital for up to 7 days. And in these teeth, you just need to remove 2 millimeters of pulp, which is superficial. You do not need to remove whole of the pulp, because only 2 millimeters superficial pulp is inflamed. Rest of the pulp is healthy. So you do not need to remove whole of the pulp. And let's take one first condition, that is enamel infraction. This is the minimal injury which can happen to the tooth. There is no change into the periodontium, only sometimes there is an incomplete crack into the enamel, which is visible with the indirect light illumination. You direct the light through your mirror, through the tooth, and you will be able to see a line. And sometimes patient feels a slight sensitivity, slight pain on taking cold, or when they inhale the cold air, they feel pain. So you can just do etching of that crack and apply a surface sealer, and that will eliminate the pain, that will eliminate the sensitivity of the patient. Now, in crown fracture, we have Ellis 1, Ellis 2, Ellis 3. For Ellis 1, where there is a minimal loss of enamel, either you can do enameloplasty or a composite restoration. Both are fine. It depends upon you, depend upon your judgment, which one to choose. But enameloplasty is certainly better because you don't add anything artificial. Patient doesn't need to keep anything, like he can't bite on these things or that thing. Patient can do whatever he wants to. So because everything remains natural. But if you do composite, certainly patient has some restrictions. So this is treatment for class 2. Sometimes patient brings a fractured crown portion, and you can very well reattach this crown portion back onto the tooth. This is a beautiful article on management of uncompleted crown fracture, in which they have reattached the fracture segment, and this is how you can reattach the fracture segment back onto the tooth. And there is one article, this is a systematic review on tooth fragment reattachment techniques, in which there are multiple techniques which people have tried, and but the conclusion of this article is when you try to unite these two parts together, if you put some intermediate material like composite, then success rate is better, then reattachment is better. Then another class 2, sometimes you can see a pink spot, there is hardly any remaining dentin, and in that case you need to give a calcium hydroxide before you do composite, and calcium hydroxide preferably you will be using a light cure calcium hydroxide. Then we have a class 3 where there is a exposure of the pulp. Here two things are very important. One is the time of injury, like in the start we discussed when this happened. Now that when has a role here. How many minutes back, how many hours back, how many days back the injury has occurred. and the extent of exposure. This is also very, very important. And depending upon that, you can choose 3 techniques. One is direct pulp cap, second is pulpotomy, third is partial pulpectomy. Because sometimes if there is a very small exposure and the patient has reported to you immediately, you go ahead with direct pulp cap. If the patient has come to you little late, but there is not much of exposure, go ahead with pulpotomy. If the patient has come to you late and have a big exposure, you need to do partial pulpectomy. That is the treatment plan. So small exposures, there is direct pulp cap, you can see in the pictures. Big exposure, delayed attention, then you need to remove a part of pulp. Now, how much pulp removal of the pulp is important? How much pulp we should remove is also very important to know. So when we do pulpotomy and when you have opened the chamber after giving LA and doing isolation and all that, when you remove pulp from the chamber, and if you are able to control bleeding with a minor pressure with a cotton pallet, that means you have left behind a healthy pulp. If the bleeding is still there, there is a oozing of the blood, that means pulp is still inflamed, and then you need to go more deeper till the time you get the fine quality of the regular pulp, so that you can apply MTA or calcium hydroxide depending upon what choice of material you have, or a Dentin, and accordingly you can complete the pulpotomy or partial pulpectomy depending upon that. So now, what is small and what is immediate? Definitely it is something subjective. It depends upon you also, that what is your clinical skill, what is your clinical acumen, what is clinical knowledge. So depending upon, you can choose the treatment. But sometimes this small and small could be subjective. Whatever I feel something small may be big for any of you, or whatever you feel is small, I may say no, it's not a small exposure, it's a big exposure. It's something something subjective. So it varies from one clinician to another clinician. So in today's day, we use MTA pulpotomy. So I'm not going to go into detail how we do it, but few steps for are very important to discuss here. Pulpotomy is basically divided into 2 broad phases. One phase is, the first phase is we remove diseased and contaminated tissue, right? And the second phase is we establish such an environment that a future bacterial contamination is prevented. And if you are able to successfully achieve these 2 phases, your procedure will be definitely successful. So when you remove affected, infected, bacterially contaminated coronal pulp tissue, and when you leave behind unaffected radicular pulp and seal it from rest of the oral environment, and then normal root development can take place. That should be the goal of our treatment. So the ideal material for vital pulp therapy should have ability to kill bacteria. It should help in recalcification. It should produce a bacterial tight seal so that no future bacterial infection can happen. And it should be a long term. There should not be a bacterial leakage for long term, so that you can keep the radicular pulp in a healthy state. That is important. So this MTA and biodentin, both 2 are material which are used as potential agents for pulpotomy, and especially for permanent teeth with incomplete root development. This is also another article, a beautiful article on MTA. They have compared MTA and biodentin as a medicament for pulpotomy, and this material has an excellent antibacterial effect, and it does not allow the future penetration of the microorganisms because it produces an excellent seal, and it stimulates reparative dentin, and it produces minimal inflammation. So overall, this is a good material for vital pulp therapy and pulpotomy. Few of the drawbacks are also there, and if I look at all these drawbacks, long setting time, tooth discoloration, and high cost. Definitely the drawbacks, but if patient can afford, then MTA is a good material, or Biodentin is a good material for that. Anyways, this tooth discoloration is certainly more with this MTA, because if you compare MTA with Biodentin, this tooth discoloration is more with MTA, but both of material can be used for this purpose. So this is what is pulpotomy. You remove part of pulp, coronal pulp, and put a dressing so that rest of the radicular pulp remains vital. So in few steps, we'll discuss about the MTA procedure. So after you have achieved hemostasis, you cover the pulp with MTA by mixing according to the manufacturer's instruction, and then you place a cotton pallet which is moistened with water, sterile water, because presence of moisture is very, very important for the MTA to set. Then MTA, after placing a cotton pallet, moist cotton pallet, you place a temporary material over it. Then you recall the patient after 1 day, remove cotton temporary filling, remove cotton pallet, and then you give a permanent restoration. If you want to give crown on the same sitting, it's okay, or you can call the patient later on. So this is the comparison of MTA and Biodentin, and you can see that color stability is better with the Biodentin than MTA. MTA causes discoloration. This is the one example of pulpotomy. You can see a continued root development. You can compare the apical area as well as the length of the tooth, and there is a continued development after pulpotomy. Then comes apexification. This apexification procedure is done whenever there is an open apex, the tooth is non-vital, there is no pulp present which can close down the apex, there is no option. You have to induce a calcific bridge formation in the root area, apex area, against which you can condense your obturating material like gutta-percha. Traditionally, we used to use calcium hydroxide to induce apexification. Even now, most of us use calcium hydroxide to induce apexification after you disinfect the root canal. The only problem with calcium hydroxide is the delay treatment, because you cannot predict how much the time is going to take for formation of a calcific bridge into the apex. And whatever X-ray you take, whenever you take an X-ray, and in the X-ray you find a radio opaque thing present on the apex, but since it is a two-dimensional picture, X-ray is just a two-dimensional picture, you cannot confirm a complete bridge formation. So main drawback of calcium hydroxide therapy is, one is the time, and second is unpredictability of the calcific bridge which is formed. So because of these two factors, and another factor which has come into picture now, that when you place calcium hydroxide into root canal for a longer time, more than 3 months, it will bring changes into the dentin. It will make the dentin friable. It will make the dentin brittle. So any subsequent trauma will break down the dentin very, very easily. These are the main 3 drawbacks of using calcium hydroxide for apexification. Now, these disadvantages we have already discussed, because sometimes what happens when you start the treatment, you have given a good calcium hydroxide dressing into the canal for the bridge formation, and you ask the patient to come back after 6 months. But patient doesn't come back after 6 months because the follow-up is a problem, because patient is comfortable, they don't bothered about it. So those are few of the things, and then is the delay treatment that we have already discussed, because sometimes patients don't have that much of time, but calcium hydroxide takes its own time for completion of the treatment. So now there is a change. We have replaced calcium hydroxide with MTA. MTA is an excellent alternative to calcium hydroxide therapy, because we can use calcium hydroxide as a apical plug. So because in many literature, if you look at the literature, this is one article which you can consult, which you can read. It's a beautiful article on MTA as a apical plug. So it has a successful clinical outcome, and it also heals the periapical area when you use MTA as a apical plug, because it needs very few number of appointments. It has an excellent apical barrier formation. It will be much more predictable than calcium hydroxide, and patient doesn't need to come again and again for follow-up. These are the advantages of apical plug. And the only disadvantage of apical plug is, since we are only closing the apex, we are just addressing the apical opening, we cannot do anything with the sides wall of the root. We cannot increase the length of the root. We cannot lead to strengthening of the root because that is not possible. So whatever the thickness of the root wall will be there, that will remain the same. Only thing is you will be able to close down the apex, against which you can do cut aperture obturation. Yes, that is possible. But otherwise strengthening of the root will not be there even with MTA. Now, something about the disinfection protocol. Whenever we do these endodontic principle disinfection protocol, I just wanted to mention few things here, because in case of young permanent teeth, because of the root canal anatomy, we are not able to reach into each nook and corner of the root canal. So the debridement is primarily biochemical. It is not mechanical. So by chemical use, we remove all remaining non-vital or degenerative or any necrosed pulp tissue. It is not mechanically, you cannot reach to each nook and corner of the root canal and space, because of their anatomy is like that. And calcium hydroxide as well as sodium hypochlorite are traditionally used as a solvent, tissue solvent, and as well as they have antimicrobial properties. But sodium hypochlorite will be effective only when you are using it. But calcium hydroxide needs additional exposure time. That's the reason you have to place calcium hydroxide into the canal for a week, so that it can disinfect as well as it can remove whatever the remaining pulpal tissue is there. And there are use of multiple antibiotic medicines, like you can use a combination of metronidazole, ciprofloxacin and minocycline. That is, a Tropez group has recommended this mixture, and this can also be kept into the root canal as an intracanal medicament to disinfect the root canal space. Even we can use MTAD, that is by Dent Supply, because this is a mixture of doxycycline, it is a mixture of citric acid and a detergent. So all these three components will help in disinfecting the root canal space as well as removal of the smear layer. Because of citric acid, smear layer will be removed. Because of doxycycline, it will help in disinfection. Now, nowadays we are using this platelet-rich fibrin a lot. In pulpotomy also we are using platelet-rich fibrin. So this is one article which you can read and know about platelet-rich fibrin. And platelet-rich fibrin, because of presence of platelets, is a reservoir of a slow continuous release of growth factors, because there are presence of growth factors that really help in pulp to recover. And PRF preparation is not very difficult. We take 5 to 10 ml of patient's own venous blood and we transfuse it at 3000 RPM for 10 minutes. When you do it, you get this kind of picture, and PRF will be in the middle and RBCs will be at the bottom and plasma will be on the top. So you have to discard the plasma, and with the help of tweezer you can take out this PRF and you can squeeze PRF between the gauge piece. So, and it will be like a flat shaped structure. So you can cut whatever amount you need, and you can place this PRF membrane over the pulp stump once you have removed the infected coronal pulp. So over the radicular pulp, you have to place this pulp, PRF, and it really helps the patient. So now you can do so many things. You can use PRF along with MT also. You can use alone PRF also. Lot of research is there. Lot of evidences are there, and successful evidences are there. You can try. It is up to you which treatment plan you follow, but you can do lots of experiments, and these are evidence-based experiments. And now you may get a patient of concussion, you may get patient of Intrusive Luxation, Lateral Luxation, Intrusive Luxation, or avulsion. So one by one, we will take up all these. So whenever there is a concussion, a slight trauma is there, actually nothing is there, slight mobility is there, you just need to give occlusal relief. Sometimes patient feels tenderness when they occlude, so you can do occlusal relief by grinding the opposite tooth. Advise the patient to take soft diet for 2 to 3 weeks. Supplanting is necessary, it may not be necessary, or sometimes patient if feels pain, and then you can give supplanting for a week to give a relief to the patient. But follow up for a year is very, very important. You must do the follow up for a year and do the pulp vitality test and a radiographic assessment continuously. Maybe after every 3 months you can recall the patient, and next time 6 months, and then a year, so that if you feel there is any change in the lamina dura or any periapical pathosis is there, or there is no further growth of the apex or the root length, that means the pulp has become non-vital, and then you can do the treatment. But if the tooth is continuously developing, the root length is already going on, and the apex is getting closed, then you don't need to go ahead with any kind of root canal treatment. Just follow up is important. Then in case of laterally luxated tooth, sometimes it is also associated with alveolus fracture. Alveolus fracture is there, and when you if you try to reduce this tooth, then that apex is engaged into the bone, and you are not able to do it. So for that, it is important that you place your finger into the vestibule. First of all, you have to push the tooth palatally, the apex palatally, and then you should reduce the tooth. And then supplanting for 2 to 3 weeks is important whenever there is a alveolus fracture, and then you need to monitor for pulp vitality. And if you feel there are signs of apical pathosis, then you do root canal treatment. Otherwise, root canal treatment is not at all indicated without the signs of apical pathosis. In case of laterally luxated tooth, this is a good article on laterally luxated tooth. Pulp canal obliteration is one of the complications, and then it could be pulpal necrosis, then it could be inflammatory resorption. In case of inflammatory resorption, you need to go ahead with root canal treatment. There is no option. But in case the tooth is vital, you do not need to go ahead with root canal treatment. But if there is a resorption, then you have to do a root canal treatment. Then in case of intrusive luxation, this could be a case of intrusive luxation. Whenever there is an intrusive luxation, there is a lot of rather maximum damage to the pulp as well as the periodontium. And there could be ankylosis. But in case of, fortunately, in case of young permanent tooth, the re-eruption is anticipated. You just have to follow the tooth. Within 7 to 10 days, you will see re-eruption happening. And you need to continuously monitor the tooth radiographically. If re-eruption does not happen in a month, then you can orthodontically reposition tooth. And root canal treatment is only indicated if there is any apical pathology, apical changes. Otherwise, root canal treatment is not indicated. And another thing is, if you find any external or internal resorption, then root canal treatment is needed. But in these cases, not 1 month, you have to follow the tooth for 5 years. Extended time of follow-up is needed. Like in these patients, if the tooth is not re-erupting, you can surgically reposition the tooth and do subplinting. And this is another where you can orthodontically extrude the tooth into a proper position. Then is the avulsion. In case of avulsion, there are few indications of, contraindication of reimplantation. Otherwise, in case of avulsion, reimplantation is the best thing. Because if you do not plan to reimplant the tooth, that means your decision is irreversible. So you cannot save the tooth, because at that time only you can plan either to reimplant or not to. So it is always better to try to do reimplantation, try to save the tooth. The contraindications are very severe caries, severe periodontal disease, very uncooperative patients, the patients who have severe cognitive impairment and you need sedation. Severe medical conditions like immunocompromised patient is having a severe cardiac condition. But in any case, try to do reimplantation, try to save the tooth. You may be saving the tooth for a short time, but nothing like the original tooth. So the recommendations which are instructions which are recommended for patients as well as for us is we need to calm the patient, ask the patient to find the tooth, pick the tooth by crown, not by the root, because you have to tell you pick the tooth from the white portion, not from the yellow portion. Do not touch the root. These are the instructions you must give to the patient whenever the patient calls you on phone, because most of the time teacher will call you that our student has fall and the tooth has come out, what to do now. So you need to give these instructions and ask the patient to clean the tooth, wash the tooth gently into water if not possible, put into milk if not possible, patient saliva, and they should try to reimplant the tooth back into socket if it is possible. And once the tooth is returned into position, they should bite on a gauze piece or handkerchief or a napkin and then hold the tooth, hold that napkin into place. And they should, and if they are not able to do all these things themselves, ask the patient to place the tooth into some storage media and they should come back to your practice. That is important. Tooth should never be kept dry. That is very, very important, because immediate treatment is important for the success of reimplantation. Immediate treatment is important because X articular time should be minimum. And this is one app which you can download, your teachers can download, all students can download. You can guide all your patients to download this app. This can help the teachers to manage the patient of trauma. This is a free app. This is available on IADT website. So all you can download this application. This is free. Then for any avulsed tooth, the choice of treatment depends upon two factors. One is the maturity of the root. Either it is open or it is closed. The apex is closed or apex is open. Then condition of the periodontal ligament. Condition of the periodontal ligament will only depend upon the time out of the mouth or out of the storage. No other factor can decide about the condition of the periodontal ligament. So X articular time is very, very important. So this is article, I have given one article you can see on the screen. If the X articular time, if the extra alveolar dry time is more than 30 minutes, then most of the periodontal ligament fibers will be non-viable. So how to minimize the dry time? It's important. And that is only possible if we guide parents as well as teachers to manage about trauma. So whenever you get a chance, always try to guide parents and teachers how to minimize, how to manage the trauma. Now something about the storage media. This is one of the article on storage media you can all download and read this article. This is a beautiful article on which is the most recommended media for storage as well as for the transport of the Evans tooth. Among this, milk is the most recommended because milk is easily available everywhere, and this is practically possible to have this kind of storage media. Apart from milk, propolis, lots of studies are going on with propolis as a mouth rinse, as a irrigating solution, as a storage media, and coconut water. These are frequently available. Propolis may not be, but coconut water as well as milk is easily available. So this can be used as a storage media. So now the treatment protocol for teeth which have been kept in media, storage media, with the extra oral time less than 60 minutes. There are protocols, 2 protocols, this is the first one, where the tooth is not dry. It has been kept in media and the time is less than 60 minutes. Then the treatment is, you should rinse the root surface with a saline to remove gross debris. Put the tooth into a storage media when you prepare the tooth for reimplantation. Then you administer local anesthesia, preferably with the vasoconstrictor. Examine the tooth for any, examine the alveolar socket if there is any fracture, and then you irrigate the socket with sterile saline. Then with your digital pressure, gently you reimplant the tooth back into socket and check it clinically as well as radiographically. Then you stabilize the tooth for 2 weeks with a passive flexible wire of 0.016 inch or 0.4 millimeter nylon fishing line wire, because this can also be used for adults, but for children this is not recommended. Nylon fishing line supplants are not recommended for children, but for adults we can use these supplants, and it should be a flexible supplant. It should not be a rigid supplant. That is important. Whenever the extra oral time is more than 60 minutes, then it will have a poor prognosis. It will have a poor prognosis. Either it will be ankylosis or it will lead to root resorption. But because the original tooth is original one, definitely it is original one. So we must try to restore the tooth. We must try to reimplant the tooth. It may be a temporary measure, but still patient will have good aesthetic, good function till the time the tooth is there. It may be 5 years, 4 years, 3 years, but whatever the time it remains, we must try, but we should inform the patient that it may not be a long-term success. So any avulsion after reimplantation, it could lead to external or internal resorption. It could lead to ankylosis. It could lead to mobility, or if the timely treatment is not given, the tooth may go also. Whenever you do a reimplantation of a young permanent tooth, there could be a revascularization because there is an open apex, there is no infection, and the pulp may revascularize, and you do not need root canal treatment. So in case of reimplantation of a young permanent tooth, root canal treatment should be avoided after reimplantation unless there is a sign and symptom or a radiographic evidence of pulpal necrosis or any infection. The only point to note, especially for children, is the resorption is more at a faster rate than the adults. So like these patients, the avulsion was there, we simply reimplant the tooth back into socket without any treatment. Now, something about the role of antibiotics. Role of antibiotics in case of reimplantation is there so that you can prevent any infection at least based reaction, and it can delay inflammatory root resorption. So you must give antibiotics to the patient after reimplantation. So something about the crown root fractures. This is a beautiful article on diagnosis and management of transverse root fracture. You all must read this article. Now, the treatment of crown root fracture depends upon how much crown has been lost. There are two ways. One is surgical repositioning, that you bring the tooth little out, do the supplanting, and second is surgical repositioning. But all these things should only be done in case you feel it is worth doing it. Because if you feel it is not worth the effort you do for repositioning as well as doing the orthodontic repositioning, then it's better to go ahead with extraction of the tooth, whatever whatever the root is, remaining root is left. So now it all depends upon one dentist to another dentist, how they look at this. But otherwise, there are two ways only: surgical repositioning or orthodontic repositioning for crown root fractures. Then we have the root fractures. In root fractures, there could be only 4 conditions. One could be apical third fracture, it could be middle third fracture, it could be subcrestal fracture, it could be supracrestal fracture. Out of these, subcrestal as well as supracrestal fractures have poor prognosis, but middle third as well as apical third fractures have a very good prognosis. Only problem, unfortunately, with crown root fractures is these fractures remain undiagnosed, and especially when the crown fragment is not displaced. If the crown fragment is not displaced, and on a normal radiographic picture, on a conventional radiograph, you cannot sometimes see the root fractures. Sometimes you miss it, and that is only possible if by chance you had advised CBCT to the patient. Definitely then root fractures cannot be hidden, root fractures will be visible. So good radiographs from different angles as well as CBCT scans are important in the early post-trauma period to detect root fractures. Now, how much are the chances of pulp to remain vital, especially during root fractures? According to this article, 75%. This much amount of chances of pulp to remain vital. Imagine if such a great chance is there, then why we should remove the pulp? Why not to try to preserve the pulp? And when the fracture is there, and this survival, 75% survival rate is in the coronal segment, but in the apical segment, almost in all cases, the pulp will remain vital. The reason, whenever the fracture is there, the pulp is inflamed. Because otherwise what happens in a normal condition, pulp is enclosed in a hard chamber. And whenever inflamed, it doesn't have any area for release of the exudate. And that is the reason it becomes strangulated and becomes non-vital. But the best thing about the root fracture is, this fracture line is the stress breaking area. So if any exudate is formed, any inflammatory substance is formed, that get released through this fracture line, and pulp never gets strangulated. That's why the pulp remains vital and there are good chances of healing. And you do not need to remove the pulp, which is very, very important. You do not need to remove pulp from the root canal system unless there is signs of pathosis. Because most of the time, apical segment will get calcified and it becomes a part of the bone. And you need to do root canal treatment only of the coronal fragment, not the complete, the apical as well as the coronal half. So whenever there is fracture of the apical third, middle third, subcrestal fracture, a rigid stabilization is very, very important. It is never flexible and there is an extended time of supplanting. Minimum 2 months, it could be 3, but if it is in middle or cervical, it could be longer. And root canal treatment should never be done at the emergency appointment. Antibiotics not indicated, especially for the root fractures, unless the coronal fragment has been avulsed. Then in that case, antibiotics may be needed. And then you need to review the healing by doing X-rays after every 3 months. That is important. Whenever there is a supracrestal fracture, mostly the coronal fragment will be mobile. And if the coronal fragment is mobile, then it has a very, very poor prognosis. Then there is no option. You have to remove the coronal portion. And now it depends upon the remaining root portion, which whatever is left. It depends whether you can do root canal treatment or you can do post and core. It all depends upon. Even you can do crown lengthening by removing the soft tissue around the root, but it should be worth doing this effort. That is important. So now the treatment options for root canal fractures are like you can do root canal treatment only of the coronal fragment. You can do root canal treatment of complete apical as well as the coronal fragment, or by doing surgical treatment you can remove apical third and you can keep rest of the tooth like that. So root canal treatment only if it is actually needed, otherwise root canal treatment is not at all needed. If you need to do root canal treatment of the coronal segment, since there is a fracture and you are doing the root canal treatment of a coronal segment, the apex will be like an open apex. It will be a wide apex. So you need to do either apical plug, you need to make apical plug with the help of this MTA or Dentin, or you need to do calcium hydroxide dressings. Till that time there is a formation of calcific bridge at the apical portion of the coronal fragment. That is important. So for the root fracture, you need to do reduction as well as supplanting for 3 to 4 months. There will be healing from outside with the help of cemental formation. From inside, from the pulp side, there will be healing with the help of what you call odontoblast, because pulp is there, so odontoblasts are there. So you don't need to do anything, no root canal treatment, only do a good supplanting, and keep the patient under follow-up, and the fracture portion will get repaired. So this is how we do the treatment for a root fracture. So if at all, when a trauma has happened and you find external resorption, external root resorption, you immediately start the treatment. No other option is there, and you must medicate the root canal with calcium hydroxide for 3 weeks to be replaced every 3 months. Till that time you find that radiolucency of the resorptive lesion has disappeared, and after that you can go ahead with the root canal treatment. And always use rubber dam for doing endodontic treatment for these teeth. But if the tooth which is traumatized, is painful, is injured, do not apply your retainers on those teeth. Always apply retainers on the adjacent teeth, not on the tooth which is already traumatized. Even you can use dental floss or stabilizing cords to stabilize the dam. That also can be used. This was a good study by Dr. Gopi Krishna and Dr. Kandaswamy. Then for the patient, care of the injured tooth is important for optimal healing. The patient should prevent further injury. Good oral hygiene with the help of brushing if possible, or by use of chlorhexidine mouthwashes. And if a very young patient cannot do mouthwash, then you can apply chlorhexidine with a cotton swab. But neat and clean area is very, very important. And if we do not give the right treatment at right time, although you are able to save this tooth by doing many treatment, but since you are not able to strengthen the side wall, any subsequent trauma will fracture the crown, and you will only left with the option of extraction. So in conclusion, although these traumatic injuries are very, very difficult challenge for patient as well as the dentist, but with the current evidence, especially the newer guidelines like IDT has come up with the newer guidelines, so if we do the treatment with all evidence-based treatment options, I think we can make a hopeless situation into a very, very satisfactory outcome for the patient. And we all have a very, very important role in a team approach in the treatment of patients with traumatic dental injuries. So this was my presentation, and now
Sure.
we can take up questions with permission of my sir, Dr. Rakesh Krishan Gupta sir.
A very spine-chilling presentation by Dr. Goyal sir. Your presentation has resolved and settled the doubts and the questionnaires of almost everyone. As a customary practice, I am bound to take on few of the questions from the audience on to the topic. Is there, sir?
Yes, sir.
There was a question like, is there any change in the protocol with regards to the storage environment of adults, young permanent teeth during pandemic COVID-19?
No, sir. Actually, as we have discussed in presentation also, they have recommended few of the storage medias. But as far as the pandemic is concerned, there is no change into the protocols. We can store the tooth, especially into the milk, as well as coconut water. And if nothing is available, then patient's saliva, even if that is not possible, anyone's saliva is okay. But water as such is not recommended. But as far as the COVID protocols are concerned, nothing like that, because trauma can happen anytime, anywhere. It is not something elective, it is something emergency. And even during COVID period, treatment of trauma is recommended. You have to manage the trauma, and especially if it is compromising the airway of the patient. So then even if the patient is positive, COVID positive, we have to treat that patient with taking all standard precautions of infection protocols.
Yeah. So then the next question, which was from the audience, a patient reporting after 48 hours of injury in form of exclusive luxation of a young permanent teeth. What are the conventional treatment plans if there is any change in these plans?
Oh yes. Actually, sir, if patient is coming after 2 days, obviously the pulpal ligament fibers are not at all viable. These are non-viable fibers. So before you reimplant the tooth back into socket, we need to remove those fibers with the help of curettage, doing curettage. And then you need to put the tooth into citric acid solution. You need to put the tooth into sodium fluoride solution. You need to put the tooth into doxycycline solution. Although success of the reimplantation procedure will be doubtful, but you can anytime make the patient understand that since this is your tooth and we don't want to that you should lose your tooth, we are trying this procedure, but it may be successful for a short time. But otherwise, yes, we can try to do reimplantation, although the prognosis will be very, very poor, especially if the tooth has been kept in dry state, that too for 48 hours.
Right. That's the question is, you have spoken about the incisal edge reattachment technique.
Yes, sir.
What's your view on this? How successful it is?
This is an excellent procedure. This is excellent procedure because patient gets back whatever the original tooth was. Color matching won't be a problem. Everything will be fine. Only thing is, many clinicians do the treatment in different ways, right? There is a meta-analysis which I have shared into my presentation, and I requested my audience to note that and download that article if they are interested and doing this treatment. So whenever we place something in between dentin and the fracture fragment, like composite or flowable composite, then success rate is better, the bond strength is better. Right. So, but yes, it needs another 15-20 minutes to elaborate. If our President sir gives me another chance sometime to discuss elaborately, like maybe sometime we plan for clinical procedures, like how we do it. So I would love to explain in detail, like how to do reattachment.
Right. Too good. So now another question. Right on it. How we can prevent the replacement resorption?
A replacement that is about after the avulsion. Am I right, sir?
Right. Yeah, absolutely right.
Okay. That is only possible if you keep the tooth into sodium fluoride for 5 minutes. 2% sodium fluoride solution is used to wet the tooth. So you have to keep the tooth for 5 minutes into 2% sodium fluoride so that resorption can be delayed. That makes the tooth quite successful. I mean, your reimplantation procedure quite successful.
There is another question pertaining to this only. How much normal time it take for the replacement resorption to happen in a young children, and how much time it take for the adult?
It is variable, sir. It is absolutely variable, because see, any resorption depends upon person's own resistance and immunity and cellular response, right? Because it is not standardized, and especially in young children, the resorption is very, very fast as compared to adults.
Right.
There are two reasons for it. One is the cellular response. Second is the maturity of the dentin as well as the cementum. Because in children, it is not that matured. It is not that hard. It is not that mineralized as compared to the adults. So whenever the resorption starts, it is at a very, very rapid rate as compared to the adults. But how much, it is not known, and it cannot be known also, because it is variable. It will vary from one patient to another. It will vary according to the clinical condition.
Right. Then there is another question from the audience, that how we proceed with the splinting of the subluxated teeth. Can we proceed with the splinting of subluxated teeth?
Oh yes, it depends upon. Suppose there is a subluxation which has a slight mobility and which is giving a discomfort to the patient, then definitely you can do splinting for 7 days. It will relieve the patient of pain. But otherwise, instead of splinting, even if you give a occlusal relief by selectively grinding the opposite tooth, then also it is fine.
Right. Related to this, there was another question related to the splinting only. They have asked about the different time period of splinting, like in case of a avulsed tooth, in case of extruded tooth, in case of a lateral luxation tooth, and root fracture. So they have asked about what duration of the time the splinting should be kept there.
Yes, yes. Actually, sir, actually, sir, for any avulsed tooth, the splinting time should be 10 to 15 days.
Right.
For any root fracture, now root fracture has a different category: apical, middle, cervical, in cervical, supracrestal and subcrestal. Right. So as we move from apex to the cervical, the splinting time keeps on increasing. Right. Minimum will be 2 months, maximum could be 4 to 6 months. Now it all depends upon where the fracture line is.
Right, sir. Then again, associated with the avulsion only, their question was that, is there any preparation has to be made in the socket area before the replantation of the avulsed tooth? Not at all. Only thing is, we need to check for alveolus fracture. If any fracture is there, then that fracture bone should be kept in place, and gently you have to clean the socket with the help of normal saline irrigation. We are not supposed to do curettage.
If it is visibly spoiled, then you have to do a proper irrigation. If you find any foreign body, you have to remove it. But otherwise, pressure is, though no preparation is needed, only gently with a digital pressure, you have to reimplant the tooth back into socket.
Yes, sir. Then there was a question. In case of time lasts more than 1 hour after the avulsion of tooth, both in the open and closed apex, any recommendation in the latest literature?
Yes, sir. Actually, if it is more than 1 hour, there could be two conditions in 1 hour also. Rather, four clinical conditions. One will be the tooth was kept in storage, the tooth was not kept in storage. The tooth has a wide apex, tooth has a closed apex. Now, depending upon these conditions, the combination of clinical situations, we choose the plan. But in any case, if the tooth has been kept out of socket for 1 hour, you do not need to do any treatment, root canal treatment. You just put the tooth back into socket, do the splinting, and then put the tooth into follow-up. Because for young permanent tooth, mostly there will be revascularization. But for our normal tooth, closed apex, you need to do root canal treatment, which you can start after 2 weeks. So because if you do the root canal treatment before placing the tooth into socket, then you will be increasing the X articular time more. When you do a root canal, maybe you'll take 10-15 minutes, you will be increasing the X articular time more. So we don't want that X articular time should be more increased. So it's always better to put the tooth back into socket and then start the root canal treatment later on after 2 weeks.
Sir, and then another 1 or 2 questions, and I will finish it off.
Yes.
Is any change in the incidence of avulsion of the teeth in the children during this pandemic, COVID-19?
Oh, certainly, sir. Certainly, because although there is no literature, but since we are clinicians and we know, like you are not getting now abundance trauma cases. You are not getting trauma cases now because everything is closed. Schools are not there, right? Kids are not allowed to like play outside. The transport system is not functional that way. So road incidences are less. So like that, trauma has certainly decreased. But although there is no evidence, there is nothing existing into the literature, but I think this is another area which you have opened up for study. You have given idea for the researchers to study what is the incidence of trauma, change of trauma during this pandemic. But yes, as a clinician, you get hardly any case of trauma now.
One of our friend have asked that how can we reduce the patient negligence in case if he doesn't come for the follow-up?
That is all depending upon the patient. It all depends upon our motivation, like how we motivate the patient. But otherwise, there is no set rule for everyone, right? Because few people may be very good in motivating their patients, few may not be. So it all depends upon us that how we may motivate them, and it depends upon the patient also that how serious they are about themselves and about their teeth. But otherwise, yes, sir.
One of we had asked for one question: can we use MTA and calcium hydroxide simultaneously for the pulpotomy?
Simultaneously?
Yeah.
No, sir. Actually, if we are using MTA, nothing like that. Because MTA is now a proven agent, potential agent for pulpotomy. Proven one, evidence-based. So if we are using MTA, then I don't think there is any purpose of using calcium hydroxide along with.
So it was a customary on my part to ask the questions. Your presentation, excellent. I hand over you to speak. Thank for presenting. Thank you.
Thank you so much. First of all, Rakesh sir, for being with me throughout this journey and making me so comfortable and so confident. Thank you so much. I don't have any words. And I again want to thank our respected Dada and Dr. Sabyasachi sir. Thank you for your leadership and dedication, sir. Combined with your webinars, committee, teamwork, and energy, we are now enjoying the results of your hard work, sir. And you and all your team mates should take great pride in this accomplishment, Dada sir. Your efforts will definitely are going to be remembered by many people, rather all the people, for many years. Thank you so much for giving us this wonderful platform, and especially making me part of your team. I'm really honored. I feel very special. And there are certainly many people who are unseen, and I want to thank all of them, because sometimes I feel that the beautiful things depend upon unseen people. They are none other than our very own Mr. Mukesh ji, Deputy Secretary, Dental Council of India, for your flawless execution of these events, and Mr. Mohinder ji for making all the registration pages so beautiful. Thank you, Dr. Sunil Kumar sir. Thank you, Mr. Mayank. Thank you, Mr. Khushal, for wonderful technical support. Thank you, Dr. Rahul Hegde, for always being with me. He is our torch bearer of pediatric dentistry in Dental Council. Thank you, Dr. Rahul. And so, without our delegates, our webinars cannot be successful. We cannot take place. So today, I think we have more than, I don't know the exact number, Saha sir will share, I think, in all the groups. We must be having more than 20,000, I think. My very warm thanks to all of the participants. Thank you so much once again for being with me always. And stay safe, stay healthy. Thank you. Jai Hind.
It is my again duty to announce 5 top dental colleges who are having the highest attendance in the last webinar. They are the Saraswati Dental College of Now, St. Joseph Dental College, Andhra Pradesh, JKK Nataraja Dental College and Hospital, Tamil Nadu, Saival Institute of Dental Sciences, Andhra Pradesh, and Sardar Patel Postgraduate Institute of Medical Sciences, Lucknow. Now the next webinar, next series of webinar, 12th in the series, will be on the topic adult drug interactions and effects, what every dentist should know. It will be on the 20th September at 4 p.m. Presenter will be Dr. Kirtilata Ampai, Dean and Professor, Department of Oral Medicine and Radiology, Manipal College of Dental Sciences, Manipal. Moderator will be Dr. Rajeshwari G. Anagarai, Professor and Head, Professor of Oral Medicine and Radiology, College of Dental Sciences, Davangere, Karnataka. And next is your feedback and certificate. Link will be sent to you with the certificate email. And then there is another link, you can go through that in the archives, that you can go to this website, you can download all your previous webinar as well as your e-attendance certificate from this archives of Dental Council of India. Now it is time to say thanks from my side. We have reached the end of 11th series webinar. It is my task to provide closing remarks. It is a sad task because we shall be closing the curtains on the lively, stimulating and scintillating webinar, as well as bidding farewell to all the online friends and associates. This webinar presented by Dr. Goyal sir is an outstanding example of our minds have been assailed with the torrent of ideas, information, statistics, interrogation, and definitive protocol and treatment phase for the management of traumatic injury to the young patient I am grateful to all those who have been involved in this organization of the event. I am thankful to our President, Dr. Virinder Mazumdar sir, Secretary S. Saha, all the Executive Committee member, Dr. Rahul Hegde sir, and DCI members, and my special thanks to our tactical and sporting team led by Dr. Rakesh, Dr. Sunil sir, Dr. Mayank, Dr. Soni, Dr. and Kushal, and Mr. Mahinder of DCI. I conclude, but before I have my personal opinion about these webinars. Kudos to the DCI for starting the webinar for the dental profession. We are here at the DCI, this platform DCI, we are here to make the thing very simple for the dental professional during this pandemic COVID-19. My sincere request and appeal to DCI that the contents and the messages being delivered from all the platform in form of the webinar should have the similar contents and the clarity about a topic wherever there is an established literature and the research. Things can be differing from the different platform where there is not a proven research. Because in this pandemic, our dental fraternity is in a distress phase as with all other professions. They are distressed economically, they are distressed professionally, and they are distressed socially also. So they are looking for the things to be simple. And if we go ahead with in multiple platforms delivering the different information to them, we are not serving them. We are rather adding the misery them, we are confusing them. So my sincere request is that content and the literature, and we should make the things simpler for our fellow fraternity, whosoever is giving the webinar, from whatever the platform they are giving, it has to be the same, because where there is a proven research. But it can be definitely different. So with this, I conclude the purpose of webinar has been almost completely accomplished. I hope you all take with you exciting and the lasting memories. Thank you from the bottom of my heart. Namaskar, Jai Hind, Jai Hind.
Namaskar, sir. Thank you so much. Namaskar.
Chalo.